Hello and welcome. During this presentation, we will be discussing the identification and treatment of perinatal anxiety. Speaking today are Rhapsody Mason, who is a clinical social worker with Illinois DocAssist, and Dr. Ashley Mulvihill, who is a child, adolescent, and perinatal psychiatrist and consultant with Illinois DocAssist. First, I would like to review our disclosures. Illinois DocAssist is a service for Illinois HFS providers for mental health consultation on perinatal and pediatric mental health concerns. Illinois DocAssist is funded by the State of Illinois Healthcare and Family Services, HFS. All faculty and staff are employed with the Department of Psychiatry at the University of Illinois at Chicago, but receive salary and support provided by the State of Illinois Healthcare and Family Services. Finally, all speakers have no relevant financial conflicts of interest in relation to this activity to disclose. To begin with, I would like to briefly share some information about Illinois DocAssist, which is a resource available to you as you work to address perinatal mental health in your work. Illinois DocAssist is a free statewide consultation program which aims to address inadequate access to psychiatric services for vulnerable populations in Illinois, including perinatal women and children. The mission of Illinois DocAssist is to improve the ability of primary care providers to screen, diagnose, and treat the mental health and substance use problems of children, youth, and perinatal women. In order to achieve this mission, Illinois DocAssist provides psychiatric case-based telephone consultation focused on perinatal mental health and substance abuse, medication-assisted therapy, or MAT, and pediatric mental health and substance abuse. Illinois DocAssist also provides researched and vetted community referral resources such as psychotherapy, support groups, and psychiatric treatment options, among other resources. We include wait times and eligibility criteria with consideration to insurance so that the healthcare provider can make an informed decision with the patient for the best possible treatment plan. We offer educational events such as workshops and case consultation rounds to groups of providers as well as CME trainings like this one. On our website, you can find resources and information on pediatric and perinatal mental health topics. We also offer medication charts and treatment decision algorithms, and this is also where you can find our recorded webinars. We also offer monthly educational e-newsletters to providers who sign up for our mailing list and regular informational social media posts. Now I will cover the answers to several questions which we are frequently asked. Can I refer my patients to Illinois DocAssist? Patients can't be directly referred to Illinois DocAssist for services. Rather, healthcare providers communicate with their psychiatric consultants directly to aid in addressing the mental health concerns of their patients. Who can use the services? Primary care and other healthcare providers in the state of Illinois who are involved in the treatment of perinatal women and children can access our consultation services. All Illinois DocAssist services are free. What is the response time for DocAssist consultations? Consultation requests are responded to within 1 business day, and often real-time consultations are also available. Who will provide the consultation services? Consultation is provided by board-certified psychiatrists and licensed clinical social workers who are experts in the treatment of perinatal and pediatric, psychiatric, and substance abuse disorders. Here you will find the Illinois DocAssist contact information. To initiate a consultation, the process is easy. Call the phone number listed here, or visit our website and fill out the online form to schedule a consultation at a time that's convenient for you. The objectives of this presentation are to describe the prevalence and presentation of perinatal anxiety and related disorders, to discuss the obstetric provider's role in recognition, patient engagement, referral, and treatment of perinatal anxiety, and describe important issues regarding pharmacologic and non-pharmacologic perinatal treatment of anxiety disorders. Now Dr. Mulvihill will begin by providing an overview of anxiety disorders during the perinatal period.
Anxiety is common in the perinatal period. Up to 1 in 5 women experience at least one type of anxiety disorder during pregnancy or postpartum. During today's talk, we will be referring to anxiety disorders, but it's important to remember that there are specific anxiety disorders as well as other related disorders. To go through a few, there's generalized anxiety disorder, social anxiety disorder, specific phobias, There's also major depressive disorders with anxious distress, panic disorder, acute stress disorder, post-traumatic stress disorder, commonly known as PTSD, and an obsessive compulsive disorder, commonly referred to as OCD. Anxiety can present in different ways. Typically, they can range in 3 types of symptoms: psychological, physical, and behavioral. Psychological symptoms of anxiety can include uncontrollable worries, intrusive, unwanted thoughts, feeling on edge, poor focus, and difficulty with making decisions. People describe worried content, especially in the perinatal period, as having specific worries about their pregnancy, the childbirth experience, their child's health, motherhood, their infant's health or safety, feeding of infant, as well as parenting problems. In terms of physical symptoms, women often describe heart racing or palpitations, headaches, sweating, nausea, muscle tension, insomnia, or dizziness. And behavioral symptoms can present as avoidance, so avoiding certain triggers, certain things that are causing them distress, situations, putting off tasks, and often can present as reassurance, so seeking reassurance from family members or caregivers. Anxiety can also present in the postpartum period with parenting difficulties with infant, or during pregnancy or postpartum period with older children. Oftentimes with anxiety, describe having poor mother-infant relationships, and it's important to keep in mind that anxiety and depression often co-occur. So during this slide, we want to review the difference between obsessive compulsive disorder and post-traumatic stress disorder versus other anxiety disorders in particular. Obsessive compulsive disorder often presents with prominent symptom of intrusive thoughts or images. Oftentimes, these images or thoughts involve their baby. Themes can include contamination or accidental harm, but may be violent or even sexual in nature. Due to these symptoms, women often avoid triggers such as avoiding places or situations that represent their thoughts or images. For example, a woman might fear and have intrusive images of drowning her infant. Therefore, she may avoid being in the bathroom alone with the infant or avoiding bathing the infant. OCD can often present too with compulsive behaviors. For example, when a woman has fears of contamination, she might excessively wash her baby or sterilize baby's bottles. OCD is often not disclosed to providers as women experience significant shame and fear due to these distressing thoughts or images. And we'll show that even though they have these, they do not want to act on these thoughts or images. Transitioning to post-traumatic stress disorder, a cardinal symptom of post-traumatic stress disorder is re-experiencing symptoms. Oftentimes these can present as nightmares. They can occur overnight, awake a woman for sleep, as well as flashbacks. This is also characterized by intrusive thoughts, but are typically memories of the traumatic experience. PTSD is also associated with avoidance of triggers of the traumatic event in itself. PTSD is often coupled with mood changes such as anxiety or depression, and PTSD is associated with changes in arousal, and women will experience hyperarousal and hypervigilance, especially when they are in the presence of a trigger. When these symptoms are bad, they may also experience things feeling unreal, or like that they aren't real, or what they're experiencing ain't real. We coin this dissociative symptom, so derealization, depersonalization. It's important to recognize that maternal anxiety can negatively impact both a mother and her child. During pregnancy, these symptoms are related to increased risk of poor self-care, decreased obstetric visits, increased risk for postpartum depression, and increased use of substances during pregnancy. These symptoms can also affect the pregnancy itself, with increased risk of miscarriage, preterm delivery, low birth weight, and preeclampsia. We can see that these symptoms also affect baby and can result in delayed and early cessation of breastfeeding, which has both physical and psychological benefits for both baby and infant. We also see increased rates of anxiety and mood disorders in offspring, as well as increased risk of ADHD and behavioral problems.
Throughout the past decade, perinatal mental health has come increasingly into focus among experts in healthcare. Several professional groups have put out statements and recommendations for identification and treatment of perinatal depression. Despite the prevalence of perinatal anxiety disorders, as of now, there is less known about the applicability of existing anxiety screening instruments in this population. At present, there is no anxiety disorder screening tool which is widely recommended specifically for perinatal women. Given the high prevalence of perinatal anxiety disorders, the risk of significant maternal-infant impacts, and the increasing availability of evidence-based treatments such as CBT, there is a compelling case for the implementation of routine anxiety screenings in perinatal populations. This is broadly recognized among researchers and clinicians. The American College of Obstetrics and Gynecology recommends screening for depression and anxiety at least once during the perinatal period using a standardized and validated screening tool. Full assessment of mood and emotional well-being during the postpartum visit is also recommended. ACOG endorses screening even when treatment is not available, as screening itself might help women to have more self-knowledge. The Illinois Perinatal Mental Health Disorders Prevention and Treatment Act was put into place in Illinois in 2008. This bill mandates offering screening and providing information for frontline healthcare workers who see women and their babies during the perinatal period. Postpartum mood disorders are broadly defined to include anxiety in this bill. Lastly, the U.S. Preventive Services Task Force recommends screening for depression in pregnant and postpartum women, and there's pending recommendation for screening for anxiety as well. When planning frequency of screening for perinatal mood and anxiety disorders, it's important to have a routine and universal system in place and to screen repeatedly in pregnancy and postpartum. We know that many patients who are struggling will not disclose mood and anxiety symptoms the first time asked, but are more likely to with subsequent screenings. Postpartum Support International recommends screening in each trimester. Postpartum screening is recommended at the 6-week postpartum OB visits as well as the 6 and 12-month postpartum visits. Additionally, pediatric providers should screen at 3, 9, and 12-month well-child visits. Anxiety prevalence peaks soon after the birth and decreases progressively throughout postpartum period. Screening between 4 and 6 months postpartum is important because the birthing person should be regaining previous functioning at this point. But also, many women have returned to work around this time, and so the significant transition can exacerbate anxiety symptoms. The Edinburgh Postnatal Depression Scale is a 10-item self-report measure with total scores ranging from 0 to 30. Although originally developed as a screening tool for depression, more recently, the EDPS has been assessed for use beyond depression, including as a screening for anxiety. For many practices, it's not feasible to add another screening tool for anxiety, so the Edinburgh is a good choice for screening for both anxiety and depression, especially if it's already being used routinely in your practice. It's fairly quick to administer and score, and is cross-culturally validated and available in many languages. A score of 5 or greater on the subscale indicates likely anxiety, and an overall score of 10 or above on the entire Edinburgh indicates likely depression. The EDPS is a reliable and valid measure of mood in fathers as well. Screening for depression or anxiety disorders in fathers requires a 2-point lower cutoff than screening for depression or anxiety in mothers. Here you can see an image of the full 10-item EDPS. The 3 questions comprising the EDPS anxiety subscale are: I have blamed myself unnecessarily when things went wrong, I have been anxious or worried for no good reason, and I have felt scared or panicky for no very good reason. These are items 3, 4, and 5, and should be scored separately with the scores being looked at separately. It's important to note that women with high scores on the EDPS anxiety subscale may not score high on the overall EDPS score, and consequently might not be flagged if only the total score is used. For this reason, it's important to look at the subscale score. The Generalized Anxiety Disorder 7 or GAD-7 screening tool is another option which can be used within OB practices and primary care. It is a self-completed 7-item scale and takes only 5 minutes to complete and score. It's available in multiple languages, and it uses some DSM-5 criteria for generalized anxiety. However, its utility as a screening tool extends beyond generalized anxiety disorder, and it has evidence of efficacy for panic disorder, social anxiety disorder, and PTSD. The GAD-7 scoring is simple. The cutoff score is equal to or above 8, which indicates likely anxiety, and there is a severity scoring, 0 to 4 being minimal anxiety, 5 to 9 mild anxiety, 10 to 14 moderate, and 15 to 21 severe anxiety. Let's take a quick look at the GAD-7 screening tool. Here you can see the 7 anxiety screening questions, as well as the ease of use for scoring. It has a severity score and so can be useful in determining level of intervention needed and tracking response to treatment over time. Please note that the 2 scales I mentioned here can be found linked on the Illinois DocAssist website. Even when we do use a validated tool to screen universally at regular intervals for anxiety and mood disorders, treatment follow-up rates tend to be low. Up to 70% of women with perinatal depression or anxiety are undetected or undiagnosed, but 85% of women with perinatal depression or anxiety go untreated even if we do detect it and refer. Let's take a look at the reasons for this lack of follow-through. There are many barriers that can interfere with access to adequate treatment, including provider barriers like lack of time, information, and training. There are also patient-level barriers, including stigma around mental health, economic barriers, and anxiety symptoms themselves can interfere. Systemic barriers might include lack of accessible treatment, lack of supportive resources, insurance difficulties, and other access issues. There are specific actions that we can take as providers to increase the likelihood that a patient in the perinatal period will follow through with treatment. These are strategies that can be implemented in practice consistently when a diagnosis has been made, and women are more likely to follow through if they are told the diagnosis specifically, offered multiple treatment options with the benefits and disadvantages of both being discussed, and formulate a clear decision with the provider about how they'd like to proceed. Patients who did follow up were more likely to endorse a sense of shared decision-making with their provider. Now I'll discuss some specific strategies for communicating effectively with patients when screening for and addressing anxiety. When introducing anxiety screening tools, it's helpful to emphasize the importance of the mother's own well-being, and also normalize the practice of screening as universal. You might say something like, I ask all of my patients about their emotions during pregnancy because it's such an important part of becoming a new parent. Or, I ask every woman how she's been feeling. Please have a look at this scale and fill out how you have been feeling over the last week, and then we can talk about it. If a screening tool is declined, document and offer it again at the next visit. Let's cover a few strategies for engaging in the initial discussion when you encounter a positive anxiety screen, using a patient-centered communication skills approach. These strategies help us to focus on building rapport while gathering information and making a plan for treatment. Start by asking open-ended questions to develop a shared understanding of her symptoms. For example, you could say, I see from the results of the questionnaire that you filled out that you're having some difficulties with worries and racing thoughts. How would you describe the way you've been feeling in your own words? Or, tell me more about your difficulty sleeping. Next, you want to reflect your understanding of the woman's story by summarizing using some of her own words. You could say, I hear you saying that you feel on edge and afraid something bad will happen to your baby. Once you've heard and reflected understanding of some of her struggles, you can start to provide information. Remember, it's important to name the diagnosis and connect the symptoms that she's having to the diagnosis. So you might say something like this. It's natural to feel some worry during pregnancy, but when it reaches the point of interfering with your day-to-day life, like your ability to rest or function at work, this is a sign that you might need some help for the anxiety that you're experiencing. Sometimes in cases where a patient may have some hesitance around the diagnosis or treatment, It's necessary to acknowledge self-determination and ask permission to provide info in order to eliminate the risk of a practitioner assuming expertise of the mother's emotions or situation. This could sound something like this. Many women feel this way during pregnancy. Would you like me to share some information that other women have found helpful with prenatal anxiety? If she consents, you can then go on to say, one thing we've seen for other women who have anxiety in pregnancy is that therapy helps with relaxing and letting go of worries. That, combined with the right medication, many mothers found that they were actually in a better position to meet their baby's needs. What are your thoughts about that? Finally, we go on to discuss her treatment preferences. We can say things like, what treatment would you like to have? Or how will we know when the treatment is working for you? Also, if you were to start therapy, how might it help for you? There are several important messages that all patients experiencing anxiety or mood symptoms need to hear, and you can integrate these throughout your assessment and treatment conversations. First, you are not alone. Other mothers experience this. Connection and support will help you. You are not to blame, or this is not your fault. We can say, this is not something you caused. This isn't a reflection of your ability as a mom. And anxiety and depression are diseases like diabetes. With help, you will get better. Anxiety symptoms are treatable, and it's a sign of strength to reach out, and it can get easier. Finally, we want to instill the message that by helping yourself, you are helping your baby. When you're at your best, you can be the best parent for your baby. Now I'll transition to discussing effective treatment interventions. Cognitive behavioral therapy, or CBT, is considered the psychological treatment of choice for perinatal anxiety disorders. This approach to mental health treatment is based on the idea that dysfunctional thought patterns lead to negative feelings and unhealthy behaviors. Cognitive behavioral therapy focuses on modifying maladaptive thoughts and cognitive distortions and changing behaviors that maintain the patient's distress. Many clinicians also integrate interventions of mindfulness and relaxation into CBT. Effective CBT includes an aspect of homework or practice of skills outside of sessions. Literature suggests that symptom reductions after the completion of even brief CBT for anxiety and related disorders are durable, with changes maintained up to 3 years post-treatment. The best effect of CBT is in individual settings, not group therapy. CBT skills are effective in treating comorbid anxiety and depression. It's also effective in treating panic disorder and specific phobias, such as fear of childbirth, fear of blood or injections, and other phobias. For OCD and phobias, CBT with heavy emphasis on exposure to anxiety-inducing stimuli is most effective. Interventions that contain an element of exposure produce larger effects than those that do not for women with perinatal anxiety. Exposure is well established as one of the most effective components of anxiety treatment. An example of an exposure is gradually exposing a patient who is experiencing anxiety about driving with her baby to the experience of driving. She might start by imagining driving with the infant, then getting into the car with the infant, then starting the car, and then driving shorter and progressively longer distances. Interpersonal psychotherapy is another therapeutic intervention commonly used with the perinatal population. Interpersonal psychotherapy is based on the principle that relationships and life events impact mood and that the reverse is also true. This therapy approach is designed to help people address current concerns and improve interpersonal relationships and life transitions. Interpersonal problems such as low social support, role transitions, and marital dissatisfaction are strongly associated with symptoms of depression and anxiety in the perinatal population. Studies show interpersonal psychotherapy reduces symptoms of depression and anxiety and improves relationship quality, social adjustment, and social support. Mindfulness-based interventions focus on developing the capacity to observe one's own changing mental and physiological states and sensations without trying to change them. A patient would practice attending to present moment thoughts, feelings, and physical sensations without judgment. The practice also develops tolerance for distress and develops relaxation skills. Mindfulness training is known to reduce anxiety and stress in general populations, but more data is needed for pregnant and postpartum women specifically. Social connection and reducing social isolation is so important in addressing perinatal anxiety and mood disorders. This can be in a variety of formats, including perinatal mood disorder support groups, which could be in-person or virtual, breastfeeding support groups, yoga, and prenatal and postpartum fitness classes. When you use Illinois DocAssist to consult regarding a case, we can also look into the best options in the patient's community for treatment and social support groups. Postpartum Support International offers virtual groups specifically around anxiety in the perinatal period, and also groups for partners and for pregnancy loss. These are free of charge and registration is available on their website. Consider referring to other non-therapeutic supportive resources as well. These can include early intervention. Within early intervention, postpartum depression or anxiety can be considered a qualifying risk factor for early intervention. In-home social work and family therapy can be available. Consider referring if family functioning is impaired, the mother has limited social supports, or the baby displays signs of social emotional maladjustment, difficulties with attachment, or other developmental delays. Informal parenting groups and new baby groups can often be found in the local community through libraries or community pages on social media. Additionally, consider referring to La Leche League, the Fussy Baby Network, or home visiting programs. Doula programs can also be useful. There are also several reputable online CBT and mindfulness apps which can be helpful. Perinatal support lines can also be useful to offer support and encouragement. The North Shore Moms line within Illinois is a great resource, as well as Postpartum Support International support line. New in 2022, a national maternal mental health support hotline was introduced and launched. On the perinatal mental health section of the Illinois DocAssist website, displayed here, you will find resources for patients which I have mentioned in the previous slides, including support lines, crisis lines, apps, support groups, and other resources. You will also find free printable informational handouts for patients and information and resources for providers, including screening tools, medication charts, and treatment algorithms. I'm going to shift to discuss some specific interventions for insomnia, which is often a symptom of anxiety in the perinatal period. Sleep fragmentation is common in the perinatal period due to caring for a baby, changes in hormones, and life stress. Sleep can impact functioning and management of medical and mental health conditions. Pregnant women can specifically worry and ruminate about their pregnancy and fetal infant health at night, which is linked to perinatal insomnia, anxiety, and depression. Normal sleep changes with birth of a baby usually occur, including spending long periods of awake time in bed, sleeping later, and daytime napping. These can be adaptive, but for some women this pattern turns into chronic insomnia, even when baby is sleeping for longer periods. Insomnia is common, and significant insomnia can be exacerbated by anxiety, but also increase anxiety and worsen daytime functioning. To address this, we want to offer sleep education and sleep hygiene information. So for example, coaching on finding a regular routine, arranging a cool, dark environment for sleep, eliminating screens, engaging in relaxing activity, and dimming lights 30 to 60 minutes before bed. We can also encourage women to reduce daytime naps depending on the baby's sleep schedule, and plan for a partner or family member to help with nighttime feeds. It can also be helpful to leave bed and do quiet, non-screen activities if extended periods of wakefulness occur. Women experiencing sleep difficulties can also be offered information about weaning from night feeding at 5 to 6 months when solid foods are introduced to the baby. Physiological and cognitive activation can be addressed through guided imagery and muscle relaxation, as well as mindfulness training discussed in previous slides. Regular physical exercise and early exposure to sunlight can also be helpful. Cognitive behavioral therapy for insomnia is an effective non-pharmacologic treatment for insomnia during pregnancy. This is for insomnia with or without comorbid anxiety or depression. It's a brief 4 to 6 session treatment. Strong empirical support led to CBTI being the first-line treatment for insomnia recommended by the American College of Physicians. It's not as well studied in perinatal women, but now some initial studies are coming out in support of it. CBT for insomnia includes general education about sleep and specifically sleep during the perinatal period, and information about healthy sleep habits. A key component of CBTI is restricting awake time in bed. This involves tracking total nightly sleep for the prior week through a sleep diary, and then starting with only spending that amount of time in bed, not to be less than 5.5 hours. The next step is to gradually extend the time spent in bed by 15 to 30 minutes, as long as wakefulness in the middle of the night remains minimal. So for example, going to bed at 11:30, and then 11:15, and then 11. Studies have shown that women are capable of engaging in behavioral sleep treatments such as CBTI, despite challenges such as disrupted sleep due to infant waking and nighttime feeding. The CBTI Coach app is a free app which offers CBT insomnia strategies and tools. It was developed by the VA and has been validated for use with veterans and civilians. It can be used on its own, but is not meant to replace therapy if therapy is needed. The app offers education about CBTI and how sleep works. Also, tips to help develop positive sleep routines and improve the sleep environment, as well as a sleep diary to track wake and sleep times. There are also tools to help with relaxation while getting ready for sleep and when trying to go back to sleep. Now that we have reviewed non-pharmacologic treatments and supports, I will turn it over to Dr. Mulvihill, who will discuss pharmacologic treatment options.
Pharmacologic treatment of anxiety disorders. Anxiety, PTSD, OCD, and depression all have similar medication treatment approaches. SSRI, SSNRI, antidepressants are also used for primary treatment of anxiety disorders. Just like in depression, SSRIs are first line. Buspar is a category B medication in pregnancy, but it does lack reproductive safety data. So we consider not using this first line for anxiety disorders. The mainstay of treatment is still to optimize SSRIs, and we want to utilize as needed medication, PRNs, to bridge when starting treatment and for breakthrough severe anxiety. As needed medication. For as needed medication for anxiety during pregnancy, we recommend first line hydroxyzine, 25 to 50 milligrams, and recommend being cautious of benzo use. In the postpartum period, you may also consider the use of as needed propranolol. For sleep problems, first line is still behavioral interventions. And during pregnancy, we recommend avoiding sedative hypnotics, melatonin, trazodone. Benzodiazepines are more studied, but we still caution use. When medications for PRN insomnia are indicated, it's preferred to use diphenhydramine or just loxamine, which have been more studied and have more safety evidence in pregnancy. There are potential risks of benzodiazepine use in both pregnancy and postpartum. During pregnancy, benzodiazepine use has been associated with potential risk of cleft lip and palate, preterm birth, low birth weight, neonatal intoxication, as well as neonatal withdrawal, and poor neonatal adaptation syndrome. During lactation and postpartum, there is still risk of sedation for mom. When a mom is breastfeeding, it's important to consider the infant's health. Is this infant full term? Is this infant healthy? Is this baby gaining weight appropriately? Potential risks of infants who are breastfed when mother is using benzodiazepines includes infant sedation, lethargy, and not waking to feed. In conclusion, we try to avoid benzodiazepines when possible. We taper as tolerated. If indicated, we recommend minimum effective dose of benzos in the shortest duration. The goal of PRN benzo use is really sparse use. Of the benzodiazepines, lorazepam is favored versus longer-acting benzodiazepine products. And if possible, we recommend that we time feeds to avoid peak concentration of benzos. Let's review medications by class. We mentioned earlier SSRIs. Those would include such medications as fluoxetine, paroxetine, sertraline, fluvoxamine, citalopram, and escitalopram. SNRIs include duloxetine, venlafaxine, desvenlafaxine. Another category of anti-anxiety medication would be buspirone. And for benzodiazepines, those commonly include alprazolam, lorazepam, clonazepam, and diazepam. Now let's review some perinatal prescribing guidelines. Number 1, you may consider switching to a more studied, safer medication prior to planned pregnancy. If a woman is looking to make a change to a medication, we recommend doing that before that woman becomes pregnant. So this way we can assess the benefit and tolerability of that medication. When a woman is pregnant or breastfeeding, that is not the time to want to be making medication changes. Number 2, if a woman is pregnant and doing well on a medication, consider continuing it even if it's not the most preferred medication. Oftentimes, women find out they're pregnant as an unexpected but desired pregnancy when they're coming in and doing well. And if we switch medications, it's potential that the new medication will not be effective and that we're exposing both mother and infant to multiple medications and now worsening anxiety, which carries its own risk in pregnancy. Number 3, when starting medications, use more studied older agents versus newer medications. Older agents are more studied and we have more reproductive safety data. When medications are new, even newer medications that came out, for example, buspar category B, we do not have enough babies born on that medication to properly assess safety. Number 4, SSRIs are first line for anxiety, just like depression. Number 5, SSRIs in pregnancy, your go-to medication is sertraline. It's been the most studied both in pregnancy and breastfeeding versus other SSRIs. And generally speaking, the safety data recommends other medications in the SSRI class before fluoxetine and before paroxetine. Number 6, restart previously effective medications over starting a new medication. As we talked about before, pregnancy is not the time to be trying new medications. The new medication might not be effective, so that's why we recommend trying a medication that was effective in the past. Number 7, consider other medical conditions, medications, and pregnancy-associated changes in drug metabolism. Some studies have shown that women's antidepressant levels may either increase or decrease throughout the course of pregnancy. Therefore, if a patient is developing symptoms, you might consider lowering their dose, or if a woman is finding a previously effective dose of their antidepressant no longer to be effective, to consider increasing it, even at super therapeutic dosing. Number 8, maximize monotherapy versus polypharmacy. It is best practice to always maximize one agent before adding new medications. This is also safest for infant outcome data. Number 9, you want to utilize PRNs during treatment initiation and for severe breakthrough anxiety. Our goal is not to keep patients on long-term, daily, as needed medications. Number 10, do not prophylactically decrease or taper antidepressants during pregnancy or postpartum. This does not benefit mom or infant and only increases the risk of her anxiety symptoms recurring. Number 11, you want to prescribe medications at the low effective dose. Our goal is to minimize the symptoms of anxiety. We do not want to undertreat and expose mother and infant to some anxiety and some medication risk. Case 1. Patient is a 36-year-old woman at 16 weeks gestational age, presenting due to concerns about anxiety in pregnancy. She has been struggling over the past 4 weeks despite weekly therapy. She experienced a miscarriage 6 months ago and fears losing this pregnancy. She has started avoiding activities due to fear of miscarriage and reading excessively about OB complications. She is having panic attacks twice a week, and her sleep and work are impaired due to her symptoms. What do you recommend? A, sertraline 25 milligrams QAM, fluoxetine 20 milligrams QAM, C, venlafaxine 37.5 milligrams QAM, D, buspar 5 milligrams BID, Or E, lorazepam 0.5 milligrams BID. For this case, I recommend A, starting sertraline 25 milligrams QAM. This illustrates point number 4, that SSRIs are the first line for anxiety. And of SSRIs, sertraline has the best safety data in pregnancy. 25 milligrams is not usually an effective dose of medication, but can minimize the risk of side effects, particularly GI side effects, which is important when a woman is pregnant. Case 2, a G1 P0 woman at 34 weeks gestational age, currently treated with fluoxetine 40 milligrams for anxiety and depression, asked about switching to sertraline due to a desire to breastfeed. Her symptoms are currently well controlled. She read that sertraline is the preferred medication for breastfeeding. What do you recommend? A, continuing fluoxetine 40 milligrams. B, decrease to fluoxetine 20 milligrams in the postpartum period. 3, advise against breastfeeding. Or D, switch to sertraline 50 milligrams daily. I would recommend A, continuing fluoxetine 40 milligrams. To review, that you may consider switching to a more studied, safer medication, but this is best done prior to planned pregnancy. This woman is a woman doing well on her medication, and we should consider continuing it even if it's not the most preferred medication. Case 3. A woman presents at her 3-week OB postpartum visit, endorses significant anxiety, which worsened in the postpartum period. She reports excessive worries, especially regarding her infant and her ability to mother, and has recently asked her mother-in-law to temporarily move in because she's overwhelmed at the idea of being alone with her 3-year-old and newborn. She cannot sleep at night and frequently checks that the baby is breathing. She endorses a history of anxiety with previous benefit with escitalopram 20 milligrams. Her son was born full term with no health problems, and she is currently exclusively breastfeeding. What do you recommend starting? A, escitalopram 10 milligrams daily. B, sertraline 25 milligrams daily. C, buspirone 5 milligrams BID. D, start clonazepam 1 milligram BID. I recommend A, escitalopram 10 milligrams daily, and this is because SSRIs are first line for anxiety. We want to be restarting previously effective medications over starting a new medication. Although sertraline is more studied and has greater safety data during breastfeeding, that medication might not be helpful for this woman. So therefore, it is best to restart a previously effective medication.
Case 4. A 30-year-old woman comes to her 6-week follow-up postpartum OB visit. She screens positively on the Edinburgh Anxiety Subscale. She discloses that although her baby is sleeping for longer stretches at night and gaining weight well, she can't fall asleep. You are asked further about her symptoms, and she reluctantly explains that she is having intrusive thoughts and vivid images about her baby being harmed or becoming sick. Sometimes her thoughts are about harming the baby herself, which she states she is horrified by and would never want to do. She cleans surfaces and baby's bottles frequently and checks on the baby repeatedly throughout the night. She is frightened to be left alone with the baby when her husband goes to work. When asked about her social supports and nutrition, she states that she does not have time for self-care because her baby needs her constant attention or else something bad will happen. What do you recommend? A, take emergency actions since she is having vivid thoughts of harm to her baby and is likely experiencing psychosis. B, wait until her next planned visit at 12 weeks and rescreen. C, refer her for cognitive behavioral therapy. Or D, refer her for supportive psychotherapy. In this case, we would recommend option C, refer her for cognitive behavioral therapy. Cognitive behavioral therapy with an emphasis on exposures is the most effective treatment for the OCD symptoms that she is experiencing. This is not psychosis, as the images are intrusive, frightening, and unwelcoming. She takes steps to avoid triggers and avoid what she fears is potential harm to the baby. Waiting to refer for treatment would very likely have a negative impact on the maternal-child bond, and symptoms are likely to worsen if untreated. That concludes our presentation on perinatal anxiety. Please see our references on the following slides that are used throughout this presentation. Please feel free to contact the Illinois DocAssist program with any questions using the contact information listed here. Thank you.